I'm going to introduce Chris Goodman, who's going to moderate the next session. Chris is Clinical Associate Professor of Internal Medicine at the University of South Carolina, and he'll be moderating the panel, What We Know About Medical Debt, a Review of Recent Evidence.
All right. Well, thanks for that introduction. I'm excited and honored to share a stage with these folks. There's a lot of knowledge here. We're going to spend the next close to an hour talking about the research or evidence base surrounding medical debt, what we know, and perhaps in some ways what we don't know. And we're going to spend about half our time in conversation together and about half our time in conversation with you all with Q&A. I'd like to make two small notes before I introduce our panel, just to plug the writing document that a number of us have been working on. That's meant to be sort of this omnibus document about medical debt. We have not finalized that document yet because we knew that this would be an important time together to learn together and sort out how we can improve on the document. A lot of you have already contributed as reviewers. So bend our ears, seek out me or someone from the Lown Institute, and of course we'll be listening and editing based on what we hear today. And then a personal note in getting started, I'm here in facilitating this panel with my research hat, I suppose, and I've spent time investigating charity care policies at hospitals and the role they play in medical debt, but I'm also a clinician, and I really appreciated some of the stories in our first panel because I think that's what drives us. I spend my time mostly in inpatient and primary care, and I see up close and personal the effects of medical debt with my patients. Did training at Emory. I practice at USC Prisma now. These are both large safety net hospitals in their areas, and I think to practice medicine, and it seems like it's more and more each day, is to encounter the problems of the cost of care in our medical system. Okay, without further ado, I'll introduce our panel here. We've got Fred Blavin, a senior fellow in the Health Policy Division at the Urban Institute. Kelsey Chalmers is the Director of Research and Data Science at the Lown Institute. Noam Levey is senior correspondent at KFF Health News and the lead writer on Diagnosis Debt, a multi-year project exploring the scale and impact of America's medical debt problem. And finally, Matthew Ray is the Associate Director of the Program on the Healthcare Marketplace at KFF. Fred, I believe you're up first, and you've brought a few slides for us. What can you tell us about the prevalence of medical debt and how big of a problem is it?
Yeah, thank you, Chris, and thank you everyone at Lown for having me here to participate in this great panel and for organizing everything, and for Arnold Ventures for their support. Yeah, I just wanted to provide a little bit more context on the medical debt problem and maybe hone in on a few of the data points that have been mentioned so far. So as this slide highlights, there is quite a bit of variation in estimates out there on the share of the population that has, or the share of adults that had medical debt, and this is all estimates from 2022. So on the highest end, there's that 41% estimate that Vikas referenced, I believe, from the 2022 KFF Healthcare Debt Survey. And this is kind of the broadest definition of medical debt out there. So this includes medical debt or dental bills that are past due or unable to be paid, are being paid off over time directly to a provider, are owed to a bank, collection agency, or other tender, are debt that's put on a credit card and is still being paid off over time, or any debt that's owed to a family member or friend who borrowed that money. The other estimates out here, the other survey estimates from the SIP, the Urban Institute Health Reform Monitoring Survey, are lower, about 15 to 17%. And the SIP question captures whether or not an individual is unable to pay a bill in full during the past year. The HRMS measure at 15% is a similar question that asks if anyone in a family had any unpaid medical bills that are past due. A smaller share of the population of adults with a credit record had any medical debt in collection. That is at 12%, and that's based off of data from one of the major credit bureau agencies. And on the far right side is the kind of the most restrictive definition of medical debt on here from a National Health Interview survey that found that 6% of adults had medical bills that they were unable to pay in full at the time of the survey. We also know that there has been a relatively downward trend in the medical debt problem. So, going back to 2017, from three of the measures that we just went over, medical debt, there has been modest declines in medical debt from 21% in the SIP survey down to 17%, from 2017 to 2022. A decline in that NHIS measure from 8% to 6% from 2019 to 2023, and a decline in the share of the population with medical debt and collections. And I'll expand upon that in a little bit and what we're seeing in 2023. This steady decline goes back even further. As you can see, starting in about 2014, during the implementation of the ACA and the Medicaid expansion, we see a fairly steady decline in the share of adults with any medical debt and collections from 18.8% in 2011 down to 13.9% in 2021. Now, there were some voluntary changes made by credit reporting agencies. I kind of think the most impactful in this instance being, stop the ending of reporting of medical trade lines under $500. And that's really why we're seeing this very large decline in 2023, where only 5% of individuals had any medical debt and collections. Now, all those individuals had trade lines above $500. So. I also want to highlight a little bit beyond just the prevalence, just kind of the variation that we see in medical debt. So this is from a study funded by Arnold Ventures, where we highlighted some of the county level of variation and disparities in medical debt and some of the drivers behind this variation. So in this study, we found that that 99 out of the 100 counties with the highest prevalence of medical debt were located in the South. As is not a coincidence, 77 of these 100 counties with the highest levels of medical debt are in states that had not expanded Medicaid. An additional 12 were in counties that had expanded Medicaid 5 years after the initial expansion option in 2014. Also, as part of this analysis, we found that the strongest predictor of medical debt in the county is the health status, essentially, of the county, the prevalence of chronic conditions. We also found that other factors associated with high medical debt are the low-income population share of the population that's uninsured, the share of the population, and the share of the population that is Black. But by far the largest predictor that we had found was kind of the health status of the county. This is very consistent with individual level data. Oh, some of those aren't here. But individual level data from surveys on the SIP that looked at individual characteristics and looked at populations that are more likely to have medical debt. And those also found that, low income, race, ethnicity, health, self-reported fair health status, insurance status are all strongly related to the likelihood of having medical debt, not just medical debt and collections. And I think I'll pause there.
Okay, great. Thanks, Fred. That was a great introduction for us. And Noam, I think you've got the challenging follow-up question to this that we struggled with in our writing group, and that's these wide-ranging prevalence estimates. Can you unpack that a bit for us?
Sure. Is that working now? Yes? No? Yes. Okay. So I have to apologize from the outset because the extremely talented members of our polling team could not be here because they're at a conference. So you're having to deal with the backup player here. But I'll talk to you a little bit about why we designed the survey the way we did and came up with a considerably higher number. And I would actually submit to you that part of the reason for that is precisely because a lot of the other measurement tools don't capture the real lived experiences of the way people are going into debt. And so, for example, not to dump on credit bureau data specifically, but for example, a very small subset of medical bills that people don't pay actually end up on people's credit scores. And that is in part because there have been changes in the reporting practices and the practices of the credit reporting agencies. But it's also just because some hospitals and a lot of providers don't report you if you don't pay your bill. So a lot, yes. And when we looked at hospitals, for example, we did a separate survey of the collection practices of hospitals. Only about a third of hospitals across the country have policies. I'm sorry, 2/3 have policies that allow them to actually credit report. I think the other thing to keep in mind is that there's an extremely high prevalence of, increasingly for hospitals in particular, of things like payment plans. People are signing up to pay a bill over 2 years, sometimes now even longer. There's a growing industry that handles this sector of revenue cycle management, as it's called, as I'm sure you know. People are asked, if you have a bill you're not paying, they might say, no, I'm paying this off. But I would argue you're in debt. You're in debt in the same way you're in debt if you're paying off a car over 5 years. Similarly, if you've borrowed money from friends or family, not typically maybe something that you would report I'm not able to pay, but extremely disruptive for the real life experience of I as a patient if I had to go to mom or dad or my brother or sister or what have you. So I think that, and finally, I mentioned credit cards. Because again, I don't think people necessarily, if they're asked about, were you able to pay this? If I put this on my credit card and I don't pay my credit card off as a regular practice, which as many of you know is pretty prevalent for us, we might say, well, yeah, I paid the bill. Never mind the fact that I'm carrying a several $1,000 balance on my credit card just as a matter of course. And so we designed our survey specifically with the idea to get at the real lived experiences of people out there. And that is why I think primarily our number was so much higher than some of the other survey data, some of the credit card data. And of course, we also include dental. And some other people don't include dental. So anyway, I'll stop there, but I hope that's helpful.
There's almost no easy sentence here, because when we say what percent of people have medical debt, we're not clear what is medical. Is dental included? What's included? What's not? What's debt? Is credit card debt? And who is the person? Like, is this debt for me? Is this debt for my cousin? Is this debt for some other people in my household? So it all becomes complicated. And how you prime the respondent and the way you ask these questions is what drives a huge variation we see amongst the federal surveys and KFF survey. I still don't think I'm on.
Well, just a little. I mean, one thing I know, like for the HRMS, the urban survey that we have, there are prompts similar to you. We ask, to include medical, to include dental, include medical debt that was paid on a credit card, for example. So they're not all. They do include a lot of these. It's not as explicit in terms of all the items that are in the KFF survey.
That's right. But I think one thing you can, and I don't want to hog all the time defending our methodology here, but if you do look at other data sources outside of actually some of the things that you mentioned, and particularly industry-based sources, you find that the frequency with which people are paying their bills is increasingly very low. So for example, if you look at research that's done in the hospital revenue cycle space, I was just looking at some research by one of these patient financing companies that found that currently the amount of patient bills that hospitals are recovering after they submit for insurance, so what the patient's responsibility is, the copay, the coinsurance, et cetera, like now it's down near a quarter. So think about that. 75% of what patients owe to hospitals now are not being collected. This is according to sort of one survey. And if you look at another survey that Gallup did, actually just asking just whether people borrowed in the last year, in the past 12 months, have you borrowed money? to pay for a medical bill, you get 30 million people. So that's just in the last year, we found 100 million people have medical debt currently. So I think when you put all those constellations together, I mean, I'm obviously very invested in this being a big problem because I think it is. But I think Matt's right. It's complicated because you have to sort of get at these things in different ways. But I mean, I think we're all here because we think it's a problem. So in some sense, maybe we don't need to argue about it.
Well, Matthew, if you could carry on that thread that was started there about the different ways that debt shows up in someone's life. It's not just a number on a bill. You know, what happens as a result of medical debt?
I mean, am I on yet? Okay. So, I mean, Noam should weigh in on this as well because he's written a small library of stories that talk about medical debt in people's lives. So if you haven't seen it, there's probably 100 or so stories to read up on. But, I mean, across the federal surveys, we know a fair amount about how debt affects people. I mean, it's pretty clear across every source that people in medical debt end up deferring care. And I think a big part of that is either they're afraid of the complexity of going into the health system and getting more debt, not understanding how to navigate the system, some of the issues we hit in the first panel. And we know that people who are similar in terms of race and age and income are more likely to delay and defer care if they have medical debt. Now, the harder bit, and there's less evidence, I think, but I think more people are working on this issue, is how medical debt impacts sort of household finances and what are sort of the long-term consequences to that. So the FinCar Foundation has a great survey called the National Financial Capability Survey. They find sort of just risky is probably the wrong word, but people in medical debt have astronomically higher shares of them are using what were called potentially risky financial instruments, using payday loaning for their banking, using pawn shops, 5 or 6 times more likely to use a pawn shop if you have medical debt. Sort of all that makes sense. And the other thing that sort of we're starting to see more evidence on is how it affects you over the long term. How incurring medical debt at one point will lead you to have less assets over time. So the panel survey of income dynamics sort of tracks how households who have medical debt even 10 years later end up with less wealth than a household that doesn't, holding constant sort of the litany of things that you'd want to hold constant in that. So, I mean, there's immediate sort of health impacts. There's sort of longer term financial impacts. Which households end up being able to finance the debt and which households are not really plays that out. I mean, one more point, just to jump on what we were just saying. The other thing that matters a lot here is how much debt you have and how capable your household will be at paying that debt off. So while we see huge shares of people who have unpaid bills, some of those will be able to finance it relatively easily, and some of them, even a small amount, will be enough to sort of derail them and spin into more and more problems.
If I could just add one sort of finding from our survey as well, was when we asked people whether they ever thought that they would be able to pay off the debt, people, not surprisingly, with high levels of debt say they never think they're going to get out from underneath it. Which, I mean, you know, there's psychological effects to that. There are health effects to that. There are obviously economic security effects of that, which are pretty profound.
You got about 3 million people in the United States who have more than $10,000 of medical debt.
And this wasn't a topic that I think we discussed beforehand, but it's I'm curious, linking the conversation you heard before, thinking about ahead of what policy changes do you want to see. How meaningful is it to frame this as a problem that's worsening, or as a problem that's improving, and how might that impact the policy decisions that we make? I'm going to start with Fred on that.
So I just want to also kind of follow up a little bit on some points that were just made. So there are a lot of studies that look at, the relationship between heavy medical debt and other outcomes. I think, I don't want to turn this into a methods discussion in the panel, but just be cautious that a lot of these are just looking at correlations within the data, so that people with medical debt are more likely to have this, but it's not necessarily a causal impact. I think, there's recent evidence from an experiment from, undue medical debt on loan forgiveness, and I think a lot of folks in this room are probably familiar with that, and found that that experiment didn't have any impact on any positive effects on improving credit access, financial distress, or mental health on average. And I think there are a lot of reasons why that could be, and it kind of maybe gets back to Noam's point where you have you mentioned 1/4 of medical bills not being paid at the hospital level. And so, like, why is that? Is it that has it gotten to the point where patients just they realize that there aren't necessarily consequences to paying their medical bills, or it's a lower priority in terms of other debts that they might have to pay off? I think that is potentially something that I think the authors have brought up as a potential reason explaining the results. And also, this forgiveness occurred a year after those loans were forgiven. So I think we're in an interesting space, though, kind of going back, that we do have this steady decline in medical debt problem. I think a lot of it is driven by the Medicaid expansion and certain policy choices, which, if certain decisions are reverted, or if there are significant cuts to Medicaid, we can see at a point right now where there's going to be a rise in medical debt, and this is going to continue to be an issue moving forward. So, it's a little bit of both. I think we're on the right track, but it's since we're not really addressing kind of the underlying causes of it per se, it's going to continue to persist.
Thanks, Fred, and to keep us on time here, I think, Kelsey, you maybe have a few slides here that we'll look at that is going to dig into the role that hospitals and especially billing practices and policies come into play here.
Chris. Oh, yeah, it's on. So I'm here to talk a little bit about a project that the Lown Institute has been working on for the past 2 years, thanks to Arnold Ventures, as Vikas mentioned earlier. So one of the solutions, like probably a very small solution to medical debt, is hospital financial assistance policies and what they offer to patients who are low income. And of course, hospitals can sort of set their own definitions of who is low income in their communities. So this data set, we have a group of research assistants led by Paula Smith here at the Lown Institute, have visited 2,500 hospital websites, downloaded their policies, and extracted the data. And that is currently live on our website. You can download a spreadsheet and look up hospitals. But at the end of this month, I think on May 28th, we're doing a big launch of a new website where you can interact with the data a little bit more, look up hospitals. We collect information about their financial assistance income eligibility thresholds, which I'm going to go into now, and also on what their debt collection practices are. So do they engage with any extraordinary collection actions, or have they committed in their policies or in their communication with us that they don't do this? So I mentioned I was going to dig into the income eligibility criteria. So most hospitals describe this as, who can apply for free care, 100% of their care will be covered. They describe this as a percentage of either the federal poverty guidelines or federal poverty level. There's a little bit of a difference there. The majority of hospitals set this at 200%, no matter where you are in the country. It's just sort of a standard thing. There's a cluster of hospitals that set it really low, so you have to be below 150% of the federal poverty guidelines to qualify for free care. And then there's a really small group of hospitals that have quite generous policies at greater than 450%. That said, there are other eligibility criteria that's not included here, things like asset tests and other things that you can find in our data set. So I'm gonna bear with me as I really dive into the data here. Each of these points is an individual hospital. On the vertical axis, we still have the same income brackets for their eligibility criteria for free care. But now we're looking at what is the median county income in these areas. So we were curious, do hospitals sort of think about who lives around them? Is it a poorer area? Is it a wealthier area? And you can see that there is a lot of variation here. So let's dive into those group of hospitals that mostly set the majority of hospitals which set their income criteria at 200%. And I'll just pull out 2 hospitals here. So we have, like I said, 2 hospitals, same income threshold. If you're at an average family making $53,000 a year, one of these hospitals is in an area with an income of $50,000 a year. So a lot of people in that area can apply for financial assistance. On the other side of this, we have hospitals, same policy, you know, they've picked it at 200% FPG. But it's in an area where the median income, I'm guessing maybe San Francisco, has an income level of $200,000 a year for the family. And this, you know, just to go back to this graph again, this variation goes in both directions. So we've got areas where the income is exactly the same. It's $100,000 across all these different hospitals and counties. And we have a hospital in an area where the median income is $98,000. But their income threshold is very generous for free care. A lot of people in this area may be receiving financial assistance. We need to link that data to be sure. In another hospital where the income threshold is set at $40,000 a year. And some of these hospitals are in the exact same area. So this is an example from where the Lown Institute is based in Boston. 2 hospitals which are a 9-minute walk from each other. At Beth Israel, you can be a family making just below 400% of the federal poverty guideline, which is $106,000 a year, and still qualify for free care at the hospital. Meanwhile, at Brigham and Women's, you have to be making below 150% of the federal poverty guidelines. We've started to publish this data. Like I said, there's a database. Will patients be able to shop around a little bit? Maybe, but I think it's important for people to be informed on this. So I'll leave it there on the data, and please play around with it if you have the chance.
And Kelsey, we'll keep it with you. Why is this meaningful? Why does this matter for medical debt?
For medical debt, I mean, yeah, like I said, it's probably a very tiny solution, but we know that a lot of people fall through the cracks when it comes to people who could be eligible for financial assistance and don't apply for it, either because they don't get the information in time or it's too burdensome to apply. The hospital doesn't have things like presumptive eligibility screening in play. And the other aspect is that because there's no regulations in most states or federally on who can apply for financial assistance, and hospitals are able to set that criteria for themselves, we get a lot of variation, and I think that's part of the reason why people are able to fall through the cracks, because it's not consistent, because we don't have standard applications for financial assistance even. So we hope with the data, like, people take that meaning away of the variation. And when it comes to things like what happens to people with medical debt, so the collection actions, the legal actions, the credit reporting even, we hope that we can start to hold hospitals a little bit accountable as well as to what they're committing that they're not doing using this website too.
Yeah, thank you. Yeah, Noam, actually, I was going to pitch it to you.
I was just going to take one issue, Kelsey, with your characterization that this is a small thing, because I think this is actually really, really important. We'll have a whole panel on it actually coming up. But
it started with your original project from KFF Health News, which had 500 hospitals roughly. So we've expanded that to 2,500 now.
Yeah, and I mean, I think hospitals obviously play an enormously important role in our in our system, and we know from the data that they're a huge source of medical debt. And I know that you've also looked at billing and collections, which I would also say, while most people are not sued or even reported to a credit reporting agency, it's hard to overstate just how devastating that experience is. And Vikas alluded to this in his introduction, that if you step back for a second and just think about the picture of a system designed to make people healthier, driving them to levels of stress that literally are killing people, I would argue it's actually vitally important.
Yeah, and expanding on that, I mean, we found that around 3 out of 4 adults who had medical debt owed some money to a hospital. So that just really kind of highlights that it's not just a hospital problem, but they're a major component.
Yeah, Fred, thank you. That was what I was going to raise too. We know where's this debt comes from bills. Where do these bills come from? And a large portion of it is hospital. I was surprised at how much was listed in looking at this data and with our writing project, how much came from labs or was listed as labs. But a lot of these labs now are also related to hospital bills as well. I think those are the majority of the sources of medical debt. The other side of the coin is insurance coverage and benefit design. Matt, do you want to talk about this one for a minute of how we know that the role that it can be contribute to or protect from medical debt?
Yeah. So what we know is that the vast majority of people who have medical debt have insurance. Obviously, if you're uninsured, you're more likely to have medical debt, but there are way more. 90% of people or so have health insurance, and we all know very well how many people have medical debt now. So lots of those people are insured. I mean, I think there's a couple of different pathways here. I think that there's sort of, you go to network accidentally, you go to network intentionally, you end up getting a service that's not covered, the dental bills, which may or may not be included in your medical package. But the other piece is the cost sharing. And what we've seen is sort of a precipitous increase in cost sharing over the last 10 years or so. So the average person with employer-sponsored health insurance is on the hook for a deductible of $1,500 before their plan pays for most things. If you've got a family, you end up having much higher deductibles. Often case, this is well in excess of sort of the typical assets that a family has. So of people who live by themselves with employer-sponsored health insurance, about a third have $2,000 in savings, all their assets put together. That's pretty close to what the average deductible is. So it doesn't take a lot in cost sharing for some households to really mess them up. And I think that's kind of reinforcing a lot of what was said earlier, is the people who end up with medical debt are people who, they use a lot of services or they use services, and that's enough to hit them, especially when they have sort of high cost sharing. How plans are designed can make a difference here. And I do think I hear more employer plans thinking about what they could be doing to help low-wage workers with employer-sponsored health insurance, make the cost sharing more affordable. After so much talk of more skin in the game, I think there is general concern that we're spending so much on employer-sponsored health insurance and the plans aren't affordable for many people who are enrolled in them. There's lots more to say on this. I'm sure everybody has something to say on this.
Can I just add one thing? Because I think, Matt, some of the work that you're doing, particularly looking at the connection between medical debt and wealth, is just so important, because when we did some work looking particularly using some of the urban data to look at racial disparities in both medical debt and wealth. And we looked specifically at a community in Tennessee, Knox County. And, if you overlay, we looked at zip code data with Fred and Breno at Urban. And, the maps of zip codes showing the concentration of African-American communities and where the medical debt is are pretty damn close. And those are also places where there's not a lot of wealth. There's not a lot of property. There's not a lot of savings. And if you think about medical debt, at the end of the day, what medical debt more than anything else is, it's a reflection of not having wealth. I mean, you don't have the savings to pay a large bill, so you go into debt. And that with your medical bill, you don't But I think one thing that people may not appreciate is sort of the cascading effects that has in people's lives, in the sense that if you're not able to pay your medical bill, you sink into debt, you don't go to the doctor, maybe you get sick, that hurts your ability to go to work, or it hurts your credit, and it makes it harder for you to buy a house and build wealth. And so you basically have a situation in which the burden of medical debt acts as this incredible weight on people's upward mobility economically. And I think some of the work that Matt's doing and others are doing too, looking at sort of these connections, is really vital, and sort of understanding that this is more than just sort of an unpleasantness. It's actually playing a really important role in affecting economic mobility in our society.
Yeah. And on the other side of that burden coin is the price of healthcare. And so, yeah, you have low incomes that can be contributing to having medical debt, but also the high costs of medical care. And so, my colleague Breno Braga, also at the Urban Institute, and I, we're trying to explore what this potential relationship is by looking at the relationship between market concentration, which is associated with high healthcare prices and medical debt, and the share of the population with medical debt collections. And we found a strong correlation between the two, similar to some of the correlations that we found in our county level analysis, not to the extent of the health of the county, but some of the other markers that we looked at as well. And then on, beyond just the commercial side, when we think about Medicaid, I think it's been spoken about several times in the slide I showed earlier and in the previous conversation, but there's also really strong causal evidence on there on the effect that Medicaid has had in reducing medical debt, not only just medical debt collections, but other measures of financial distress that could be associated with wealth, accumulation of wealth over time. And so there's a couple authors, Kyle Caswell and Tim Wademan at the Urban Institute, and then others had a similar study and found that basically, Medicaid expansion, those who newly gained Medicaid under the ACA, for those individuals, it reduced their average medical debt collections by about $1,100. So that's for the lowest income, more vulnerable populations.
Okay, we're going to popcorn this question real quick. So one final question, and then we're going to go to our Q&A. And that's, what research or what data do you feel like is missing? What would you like to see? Where would you like to see the research go on medical debt? Fred?
So something that Noam and Breno and I have been trying to get is being able to link like credit bureau data with healthcare claims data to get a better sense of what events are triggering medical debt and get a much cleaner picture of what's happening, kind of linking the clinical and administrative side with the final outcomes in terms of medical debt and collections. We've tried but have been unsuccessful so far. It's kind of a difficult linking process and finding the right partners in order to do it, but that's one thing on my wish list.
That's on my wish list too. I'd love to see that.
Yeah,
Let's work together here. I think that we talked a lot at the beginning about survey data, and survey data obviously has a lot of inherent weaknesses, but it is difficult to get this clear data from claims or what have you. One area that I sort of think a lot about is credit card data too, where we're just asking about it. We know tons of people are using their credit cards to pay for medical care, but it's very difficult. Even if you have credit card data, we had a sort of aborted, or not really aborted, but ultimately underwhelming research discussions with JP Morgan Chase Institute, and for a number of reasons they lost interest working with us. But they were not super forthcoming with a lot of their data. But these credit card companies can get very granular in terms of looking at what people are obviously spending, and then more interestingly, sort of what happens to their balances afterwards. And I would love to, if I could wave a magic wand, get at that data somehow.
I mean, I think medical debt isn't one problem, it's a lot of problems, and people end up with medical debt for multiple reasons. And I think both of these solutions are doing the same thing. They're trying to figure out how do people end up in debt, and that's going to be what we really need to figure out, what is the right policy instrument to solve the problem.
I'm just going to touch on two really quickly. One is, what is industry doing and planning that's going to impact medical debt in the future? So Chris and I wrote an article that came out this year, just thinking about what are the consequences for AI in revenue cycle management. And is that going to be a driver of medical debt in the future if patients are sort of being kicked off their opportunity to get financial assistance because of these AI tools? The other thing, speaking as a non-American, is some country comparisons. I know the Commonwealth Fund does a lot of work on this, but I think there's like I don't know if anyone saw Donald Trump's speech on the pharmaceutical price executive order that he just made. And he told the story about how the pharmaceutical prices for Ozempic were a lot cheaper in the UK. And why was that? So there may be an opportunity there to stress some of those stories. Not to say that people don't have medical debt or unaffordable care in other countries too.
Can I just add one thing to the Kelsey? Because I think that's such a great idea to look at other countries, and I think particular people in the United States who may historically have been reluctant to look overseas are increasingly desperate and may actually be open to those kinds of conversations. But one of the things that we did when we started, speaking of gaps in the data, when we started our project, I was looking to find medical debt data in other wealthy countries. And so Germany doesn't even collect that information. And you would think the Germans, and I'm a German citizen, I can dump on the Germans here, but you'd think the Germans would gather this data, but they don't even ask about it because it's sort of not really part of the picture. And in the UK, where there is a very extensive financial security survey that they do, they have asked about debt in some ways. And the incidence of medical debt there is actually lower than the incidence of gambling debt in the UK.
Wow. Yeah. And I've used healthcare and participated in delivering healthcare in Mexico and Costa Rica, and very little conversation was being had about the cost of care, on both sides of that. And I think I'll plug one thing for data needs, and that's hospital data on people that apply and the screening process for financial assistance policies, just to kind of overlap on a theme here. All right, time for our Q&A.
Right, we see Bernita over here.
I just have a quick comment and sort of a plug for a later session that I'm moderating. But the other countries question, I am glad that that's mentioned. We will talk about it later. I will add one caveat to Noam's point, that it's very important to look at non-wealthy countries as well, based on what you just said as well, because even in my experiences in Ecuador, for example, this just doesn't even come up as a talking point. But stay tuned later. We will talk about other countries.
Hi, I'm Michelle Sternthal with Community Catalyst. Two quick questions. Has there been any disaggregation by facility fees versus actual fees, or looking at what proponent of those add to the medical debt? That's one question. The other is any data on cost of coverage or type of coverage as it relates to health outcomes. My dad is my focus group, and he, as a doctor, is from Montreal. And so they'll say, oh, yeah, on the one hand, it'd be like, yeah, of course we should have a different system. But, if we were in Canada right now, your grandmother might have died already because of the wait list to get on. So thinking empirically both about the cost, but then also the trade-offs, and to what extent are they actually real versus fear-mongering the data.
Who feels comfortable with that one?
I do not know of anything to separate out the cost of professional fees and facility fees on how that's linking to debt. We do know that facility fees are going up for a lot of services, and they're going up for a lot of services faster than professional fees, especially for like EDs. So we've done a lot of work on that. So, I mean, if you want to make the leap in your own reading between what Fred was saying about prices and facility fees, that piece is done. But how that leads to debt, we don't specifically know.
Yeah, we don't have that information in the credit report data. We just know we don't even know if it's at a hospital or not. We just know it's medical debt. But that is something that we're trying to get at in a very early stages of kind of some proposal work in terms of getting more at site of services in terms of looking at utilization in like a hospital outpatient department relative to a physician office. How does that affect the likelihood of incurring medical debt? Trying to get more at potentially high areas that have high site of care utilization.
And I think the second question was trying to get at this linkage between cost of care and health outcomes, basically. Trying to return to that idea. Yeah.
Very sick people or other things, it's better to be in the US or there's a population level. And so just looking at like, where's the data to be like, no, actually, it's okay.
I can speak to that a little bit. Maybe not the Canadian experience, but the Australian experience. So I don't think the data exists. Again, we could add it to our study, which we'll do. With some funding, maybe. But on a population, I think it's, on a population level, it's not working in the US, but it works in other countries. But I have seen cases where if you have a rare genetic disease, if you have something, you raise money, you go to GoFundMe, this is in Australia, to go to the hospitals in Boston. But does that work on a population level? And it goes to Vikas's point before about earlier this morning, we could spend 100% GDP on healthcare. So everyone gets that intense level and prices skyrocket and everyone has every single healthcare thing that they ever want, but it doesn't work. And so countries do have to make those decisions and consider cost effectiveness.
I am Canadian, and my mom says exactly the same things. What we see with the data, at least, which I don't share with my mom, but we recently put out on our Peterson Kaiser Health System Tracker, is we see relatively similar utilization of the services people typically care about across sort of the OECD suite of countries. Use is pretty much the same for a lot of things. What's really different is the prices. So we just put this up, or this week or last week, or it's coming out next week.
There is some Commonwealth Fund happening here, but okay. There we go. Commonwealth Fund does actually do regular international comparisons across the dozens of metrics, and one of the sort of set of metrics that they do look at are outcome-based measures but their main one mortality amenable to healthcare, which is a debate, as many of you know, is a hotly debated metric for measuring sort of how do you capture sort of what is the function of the health system versus the broader society. It tries to disaggregate those two, but it as I said, it is debated.
Hi, Ernie Davis with the Leukemia and Lymphoma Society. On the question of hospitals engaging a bit less in collection practices, I guess my question is, has there been any data in regards to the reason they're not doing it? And is it because they're selling the tranches of the debt to third-party collectors who are engaging in some of the more egregious collection practices?
So you're sitting next to two of the experts on this topic, so I should probably let them talk to you about this. But from a data perspective, I mean, this is one of the holes, as Chris mentioned, in terms of understanding not only kind of what hospital policies are, which is what we tried to do and what Kelsey's team has done a much better job of doing, but also actually what does that translate into in terms of, what percentage of financial assistance applications are actually approved? What are the income levels of those people? And folks are trying to get that. I know $4 is also working on trying to get at some of that. We don't really have a good way of doing that. Some of this claims data is another kind of way to get at this. We really wanted in our research initially to try to understand, well, if we have a couple of hospitals in town, can we figure out whether or not like MedStar or Georgetown, or like I said, let's say MedStar or Hopkins are more or less responsible for putting people in debt just don't have that really good data for that. The interesting thing is that the data is out there because the revenue cycle management industry, which doesn't usually participate in these kinds of exercises, they just sort of run with a different crowd. They have this information, and for obvious reasons, they don't share it.
Hello, Marceline White, Economic Action Maryland. 2 questions. One is when you are looking at the data and you're looking at the number of people who are using credit cards, are you disaggregating between whether or not they're using healthcare credit cards or more traditional credit cards? Because I think that is one thing we're certainly seeing in Maryland, and there are different challenges with the healthcare credit cards in terms of their use. So I'd love to see that data. And then secondly, this is a little broader comment, but at some point when we look at healthcare costs broadly, I'd love to see some sort of study about kind of opportunity cost. And I was just thinking about that because I just looked at my Care First insurance before I pulled this up, and I was like, you know, for people with chronic health conditions, there's a lot of things insurance doesn't cover, so people are paying out of pocket. So, you know, I was like, okay, if you're spending $7,000 over a certain number of years, you're talking about, you know, hundreds of thousands of dollars of like opportunity costs or savings. So when you're thinking about wealth building, I think writ large, that's a pretty significant loss of income that's going to healthcare. So I'm just wondering, like more broadly, it would be interesting to see what that looks like for working families and, you know, everyone.
Yeah, on the first one, that's a question that we've been trying to get at, and I guess the short answer is no. Like we haven't been able to find data, at least with our credit bureau data or even on our survey data. It's just combined any credit cards, and we haven't even been able to get at medical debt that's paid on a credit card. That's ended up going to debt and collection. So I don't know if anybody else has had luck on that, but I think that's an area of.
We asked in our survey about medical credit cards specifically, but it was sort of unsatisfying in the way that, because I'm not sure a lot of people understand necessarily that this is a medical credit card. Maybe if they have Care Credit, that's obvious, but yeah, it was sort of frustrating.
And thanks for that comment too. I was really struck by that story of the that we heard earlier about the pilot license, and that's where the money went. And that, you know, that's really got to come through good reporting and good qualitative data, and we need more of that.
Sorry,
let's take the question down there first. You sure? I'm okay waiting. Okay. So I'm Lauren. I'm from the Indiana Community Action Poverty Institute. We do some work at Indiana level for state advocacy for policies related to medical debt. And one of my questions, I have 2 here, related to kind of the low end stuff. Do you have any insights into why there is variability in charity care, like eligibility policies, not just at income level, but we do qualitative work. So you're mentioning that. We do that on medical debt, on low income clients in particular. And we find that there's still very much variability in the paperwork requirements. Like some require sometimes like their titles for their cars, their deeds of the house, like if they own a house, like some require tax returns. So any insight on that would be lovely. And also in relation to medical billing errors, we find that happens a lot in Indiana as well. I personally experienced that, triplicated charges in an ER visit for an 11-day hospital visit. And it took me 8 months of arguing with the medical facility to get that adjusted. So I can't imagine somebody who's not in a position I am dealing with that. So any efforts that you know of how to define those duplicate charges as fraudulent charges? I know that there's been some efforts in Indiana, maybe just sending it to the AG's office and collecting information, be like, this charge, I'm not paying for it. So any advice or insight on those?
I'll just touch on that first question a little bit. Not that I can't answer it, sorry. But I presented this data at a revenue cycle management conference recently, and I got the comment that, oh, I didn't know other hospitals set different thresholds. I thought we all did the same. So, yeah, I don't know how they make those decisions.
And I don't want to give too much away because I think Monica Sakona from Georgetown is going to be talking about state policy, but there is a lot of variation in terms of what states are doing for their minimum financial assistance policy. So states have different minimum eligibility standards and different rules, specific rules in terms of who is eligible for them, and specific, application rules.
And they can change it for different hospital types too, as well.
Yes, most of them, some of them just apply for nonprofits, some apply to nonprofits and for-profits. So there's a really great report out there it's a Commonwealth Fund and Georgetown University fund that kind of goes at all the different state policies on that are out there and what states are doing in this area of financial assistance protection policies, but other consumer protection policies for medical debt.
Do hospitals vary within health systems?
That's a great question. You could answer it with our data, but we have not answered it yet. A lot of systems do have policies that cover all of their hospitals, although often you would find conflicting stuff between the system policy and what the hospital policy said, if it was there. So which ones apply? We weren't sure. We had to make a decision at some point, especially if we were talking to someone at the system level who was telling us, no, this should apply everywhere.
I would say presumably yes, because especially when you have multi-hospital health systems that span multiple states, they're going to be under different regulations in terms of their financial assistance policies.
The other thing too related to that, and this happens with a lot of our data at the Lown Institute, is just mapping which hospitals belong to which systems. They're constantly changing. They don't update their policies in a timely manner either. So sometimes you'd find a financial assistance policy for a hospital and realize that they were no longer part of that system anymore. So it didn't apply.
I mean, in terms of data gathering, I know some of you here from state advocates know that, right, there have been discussions at the state level in terms of requiring more reporting by hospitals, not just of what their policy is, but actually what their practice is. I mean, as a journalist, I can say I'm just, rubbing my hands together, waiting for when and if that actually comes to pass. Because then we're really going to see, why does, the University of Colorado system only approve 10% of the applications they get, and why does, another system 50%? That's going to be, I think, when you want to talk about what kind of information would move the needle, I bet that would.
I think we've got time for one last question, and I think Elizabeth was really working hard on hers.
I'll try and keep it quick. So, +1 on all the international. Lived and worked, practiced in Australia, obviously from another country where, has its problems. And a +1 for the Qualies commentary that you made, but that got politicized to death panels very quickly. My question to you is, the AI, I've worked on both sides of this. I worked with ProPublica on the PXDX piece that showed that they were using AI to deny. I was one of those people. I fought and won. If we don't have both sides of the table here, and do we have anybody from the other side of the table at this conference, we're in a nuclear arms race of AI to use this, because we're using it on the other side now to fight those claims. How do we get them to participate in this? Because without them, I don't think we can solve this. Maybe I'm wrong. I'd like to be, but I don't believe so.
Yeah, you're absolutely right. I don't know that there's an easy answer to that,
yes.
But certainly...
we're out of time.
Yeah, right. Yeah, things are changing rapidly with technology, and certainly AI is going to play a part in a lot of this, and hopefully we can bend it to our will in some way. That's part of what we're doing here. It's convening and finding ways to take practical action. So I'd like to thank our panel and for their time and their expertise.